Good afternoon, good evening, good morning, depending on where you are around the world. It's a great pleasure to be here again today for these new IATH Junior Clubs. We are going to discuss great topics with Dr. Tariq Kewan, that is an hematology and oncology clinical fellow at Yale's Smilow Cancer Centers, and Professor Amer Zeidan, that is a professor of hematology, also at Yale's Smilow Cancer Centers. We're going to discuss today the topic of older patients with acute myeloid leukemia and how we can manage them. Do not hesitate during the presentations and the discussion to send your question in the chat, and you are going to take the question at the end of the presentation and to discuss all your suggestions with my colleagues. So please, Dr. Tariq, you are invited to start your presentations.
Thank you very much, Dr. Malard. And first of all, I would like to thank IACH for having us today to discuss this topic about the management of older patients with acute myeloid leukemia. We're gonna discuss this case based on a case that Dr. Zeidan had in the clinic. So the objective for our today lecture is gonna be to discuss the treatment approach and the goal for older unfit patients with acute myeloid leukemia. Now we're gonna have a specific focus on older AML patient with IDH1, IDH2 mutation. I will start first with the case presentation. So our patient was an 86-year-old female with a past medical history of a BRCA2 mutation. She had diagnosis of ovarian serous carcinoma in 2010 that was treated with surgical resection followed by carbotaxol chemotherapy. After that, she was diagnosed in 2018 with left breast invasive ductal carcinoma that required surgical resection followed by endocrine therapy with letrozole for 5 years. She also has a past medical history of hypertension, hyperlipidemia, pulmonary embolism, complicated with the bleeding during the treatment, and hypothyroidism. She presented with a chief complaint of nausea, early satiety, and weight loss for about 6 weeks prior to presentation. She actually reported 15 pounds weight loss, and during that time, she had 3 episodes of UTI in the similar period of time. She presented to the emergency department, and the initial lab on the ED, including basic labs with complete blood count, showed pancytopenia with a white blood cells of 1.8 thousand cells per liter, with a neutropenia at 700 and hemoglobin of 10.2 gram per deciliter and low platelet at 126. Her complete metabolic panel was significant for hyponatremia, and the coagulation studies showed elevated D-dimer at 1 milligram per deciliter. Peripheral plasmia was sent, and it showed leukopenia with normochromic anemia and thrombocytopenia. And they reported a large atypical mononuclear cell suspicious for blast. Since she had a history of malignancy, a CT scan for the chest, abdomen, pelvis was done, and it showed no evidence of malignancy or splenomegaly. Peripheral blood flow cytometry was sent, and it showed no blast, just normal expression of myeloid markers. Since the patient had pancytopenia with unknown reason, a bone marrow biopsy was done, and it showed acute myeloid leukemia with monocytic differentiation. And the flow cytometry showed at least 35% blast, with a CD117 positive, CD33 positive, and HLA-DR negative, acute myeloid leukemia. Cytogenetics showed normal female cytogenetics with normal karyotype in all 21 metaphase cells, and the FISH, for AML, was negative. Molecular studies showed no translocation, including T922, T1517, T821, and the Virgin 16. A next generation sequencing panel was sent that showed MBM1 frameshift mutation at VAF of 23.6% and IDH2 R140Q mutation with a VAF of 39.4%. So to summarize, this patient presented with almost 6 weeks of nausea, early satiety, and weight loss, and she presented with pancytopenia and now diagnosed with acute myeloid leukemia with monocytic differentiation with MPM1 IDH2 mutation. Now, the first question I would like to ask here is, how are we gonna risk stratify this patient? So I don't know if you would like to interpret here, or I can continue the presentation.
No, you can just go forward.
Okay, so I will discuss the AML risk stratification based on the 2022 European Leukemia Network risk stratification. As you can see, this was recently revised and published from 2017 and 2022 in the blood. And according to this risk stratification, our patient have a mutated NPM1 without FLT3 ITD and will have a favorable risk category. However, one important point to mention is that LN risk group in AML patient above the age of 60 is not very well validated. For example, in this study done by Morzik and the group published in Leukemia this year, they showed that in 637 AML patients treated with intensive chemotherapy, that the LN22 criteria did not differentiate between these patients according to disease-free survival, overall survival between the intermediate and the adverse risk group, as you can see in the Kaplan-Meier below. And that's raised the question, why the LN risk group are not working well in elderly patient with AML, and why AML management in older patient is more challenging compared to younger patient. And I would address this question by multiple aspects. I would say the first aspect is based on the disease itself in elderly, and the second aspect is going to be based on the patient themselves. The NCCN, they defined older patient as patient age more than equal to 60 years. However, according to the LN criteria, older patients are defined as more than equal 60 to 65. And we know from multiple studies that the overall survival for AML patient above the age of 60 is as low as 3 to 8% compared to 20-30% in all other leukemia patients. As you can see in the paragraph in this slide, you can see that the unfavorable and the intermediate risk group are increasing in frequency as the age increase. And that can tell you why the prognosis is much worse in AML patients who are older or with increasing age. Another important aspect is that cytogenetics and age are major determinant of outcome in intensively treated acute myeloid leukemia patient, as shown in this blood study since 2006. You can see that patients who are above the age of 70 as a cutoff identified here by this figure, and with a high risk cytogenetics have a worse overall survival compared to younger patient or patient who are having more favorable cytogenetics. Of course, the performance status and the physical activity is highly correlated with overall survival, and the more poor performance status, the worse is the overall survival. And we know that with increasing age, the performance status is one of the limitations of starting intensive chemotherapy, and is very well correlated, as shown in the Kaplan-Meier on the right, with overall survival. And this was published by Paras and colleagues in Leukemia in 2023. Another important aspect is that elderly patients having higher rates of clinical comorbidities that may significantly correlate with worse overall survival. In this study from the Danish AML registry, they included about 2792 patients with AML, and they correlated with overall survival based on the number of the comorbidities and the Charlson Comorbidity Index and the performance status based on the WHO. So as you can see in the figure P, in the patient, all the patient and patient treated with intensive chemotherapy, the higher the number, the comorbidity, the worse is the overall survival. And as you can see how the overall survival is significantly different based on the WHO performance status, while patient having performance status more than 1 are having more worse overall survival. Another important aspect, as I mentioned, is that the spectrum and the prevalence of the genetic mutation in elderly patient is totally different from younger patients. And according to that, I think we're dealing with another entity of leukemia among elderly patients that behaving in an abnormal way or different from younger patients. So as you can see in this a study that looks at the genetics of AML in patients 75 years or older treated with intensive chemotherapy, we can see that the older patients have higher rates of TIT2 mutation, SRSF2, SXL1, and TP53. And patients with IDH1 mutation and NPM1, like in our patient, have worse overall survival compared to the wild type. So putting all these factors together, when we're talking about AML in elderly patient, there are multiple aspects related to the patients themselves in terms of multiple comorbidity, worse performance status, and maybe we are dealing with a more aggressive disease with a different genetic configuration that's actually leading to more poor overall survival and event-free survival. Now, the next question back to our case is that how are we gonna approach the management of this AML patient who is 86 years old? So how are we gonna approach the AML patient and elderly? Since our patient is having IDH1, IDH2 mutation, I love to include this diagram from Isa and colleague that was published in the Blood Cancer in 2021. So the first step is to determine whether the patient is going to be fit for receiving intensive chemotherapy or not fit. And as you can see, they mentioned if the patient is above the age of 65, although it's not an absolute indication or unfit, we can consider treating with less intensive regimen, including hypomethylating agent and venetoclax. Or sometimes we can use single agent IDH inhibitors, especially if the patient is more than 75. And we will discuss multiple trials from where like these data are coming from. However, if the patient is fit for receiving intensive chemotherapy, we can consider giving the patient 7+3 induction chemo, and we can consider a clinical trial with the addition of ivosidenib, enasidenib, or venetoclax, which are IDH1, IDH2 inhibitor with BCL2 inhibitor. And then we can risk stratify patient and assess the patient for fitness for possible PMT or allogeneic bone marrow transplant. So now, how are we going to define the unfit patient? And I think this is a very important question because I got these like criteria from the Ellen like risk stratification published in the Blood. And this is the criteria used by multiple clinical trial to risk stratify patient in clinical trials. So patient age more than or equal to 75, although this cannot be absolute criteria for unfitness because some patient might have good performance status, although their age is more than 75, and they can still be fit for receiving intensive chemotherapy. Or having a poor performance status defined more than or equal to ECOG more than 2, or age-related comorbidity, including severe cardiac disorder with ejection fraction less than 50%, severe pulmonary disorders, creatinine clearance less than 45, or like hepatic disorder with total bilirubin more than 1.5 upper limit of normal, or any other comorbidity based on the physician that determine or making the patient incompatible of receiving intensive chemotherapy. So according to that, going back to our patient age was 86. It was like, more than 75, has some multiple comorbidities with multiple cancer diagnoses in the past, treated with chemotherapy, and was determined to be ineligible for induction chemotherapy. So I'm going to discuss the options that we discussed with the patient at the first visit regarding the treatment of the AML. And the first option we discussed with the patient was the standard of care azacitidine hypomethylating agent, or decitabine, with venetoclax based on a VIALE-A clinical trial. So the VIALE-A was one of the pioneer clinical trials that led to the approval of azacitidine and venetoclax combination, the treatment of unfit patient, acute myeloid leukemia. The inclusion criteria were ineligible patient for induction chemotherapy, more than or equal 75 years of age. They could be 18 to 74 with having multiple clinical comorbidity. And the patients were randomized in 2-to-1 fashion to receive either venetoclax azacitidine combination, and they included 286 patients in this arm, or receiving azacitidine alone. And the primary endpoint was overall survival, and they looked at multiple secondary endpoints, including complete remission and complete remission with incomplete hematological response. Now, as we can see from the primary endpoint, the Kaplan-Meier, that the patients who were treated with the combination aza-venetoclax had a longer significant overall survival of almost 14.7 months as compared to 9.6 months in the azacitidine alone. There was significant improvement in the overall survival in this arm that established a new standard of care for older unfit patient AML. In the subgroup analysis, as you can see on the right, I already marked the IDH1 and the IDH2 mutation, since in the subgroup analysis, they showed a more favorable outcome for azacitidine venetoclax among patients who are having IDH1, IDH2 mutation. And actually, this was like followed by, I will discuss the other like study that looked more specifically at patient IDH1, IDH2 mutation from the VIALE trial. Now, regarding the safety issues, patient on the combination group, they had more hematological adverse event in terms of thrombocytopenia and febrile neutropenia. And why I mark that here, because if you remember when I discussed our patient, the presentation was with pancytopenia and recurrent infection. And of course, like given the patient combination of azacitidine venetoclax, gonna put the patient at higher risk of febrile neutropenia, maybe more severe infections. Now, this is the analysis study that I mentioned that looked at pooled biomarker analysis from the VIALE-A and the phase 1b study for venetoclax azacitidine patient that looks more specifically at the effect of aza-venetoclax combination among IDH1, IDH2 mutated patient. And you can see in the combination arm, they included 81 patients as compared to 28 in the azacitidine alone. And they have patients with IDH1, IDH2 with NPM1 mutation, about 15 patients. And they looked at the remission rates. As you can see in the panel A, this is the wild type on the right, and the IDH1, IDH2 mutated on the left. And you can see the higher remission rate with venetoclax azacitidine as compared to azacitidine alone. And when you look at the patient with IDH1 mutation, we can see the higher remission rate compared to the azacitidine alone, which was similar in IDH2 mutation. And when they risk stratify the overall survival based on the IDH1 mutation, you can see how in all the subgroups, patients who were treated with azacitidine venetoclax has a significant better overall survival. Even the wild type, but this difference was more significant among patients with IDH mutation. And this is suggestive that venetoclax azacitidine combination can work very well among patients with IDH1, IDH2 mutation. And another option we discussed with our patient is option 2, which was a low-dose cytarabine with venetoclax combination based on the VIALE-C trial. The VIALE-C is another important trial. It was a randomized phase 3, double-blinded trial that looked at low-dose cytarabine venetoclax combination versus placebo plus low-dose cytarabine. And in this study, the primary endpoint was overall survival. Venetoclax plus low-dose cytarabine does not improve overall survival, but it actually improved response rate, transfusion independence, and patient-reported outcome versus low-dose cytarabine alone. However, when they added 6 months for the follow-up, as you can see in the Kaplan-Meier on the right, there was a significant difference in the overall survival. However, during the time of the study, there was no significant difference in overall survival. Option 3 we discussed with our patient is the use of IDH2 inhibitor, enasidenib, with azacitidine on and off a clinical trial at the time of the patient presentation. And the option 4 was the use of IDH2 inhibitor, enasidenib, as monotherapy with this supportive care alone. Our patient decided to proceed with monotherapy of enasidenib, 100 milligram daily. And this is the algorithm for the treatment of our patient. So we started 100 milligram daily, and you can see the white blood cells at the time of the start was 1.3, and the patient had 13% peripheral blood blast. 6 weeks after the presentation, she presented with cough, shortness of breath, lower extremity swelling, and skin rash like erythematous in the upper and the lower extremity, as shown in the picture here. And there was a concern for differentiation syndrome after the start of IDH2 inhibitor. As you can see, the white blood cell count went up to 27.3 with leukocytosis, and the peripheral blood blast went down to 3%, which is actually compatible with differentiation syndrome. We started dexamethasone 4 milligram PID, and 8 weeks later, the white blood cells went down to 4.3, and the hemoglobin was 11.6, and the peripheral blood cells were 0%. We repeated bone marrow at that time, and the bone marrow showed normal cellular tri-lineage differentiation, and there was no blast. However, the NGS sequencing show NPM1 IDH2 mutation consistent with persistent AML. 2 years after, the patient continues to follow up with enasidenib 50 milligram daily because we reduced the dose due to differentiation syndrome, and she continues to be in complete remission. However, she presented with bone pain in the scapular area, and she was found to have bone metastasis from the breast cancer, and she decided to go with comfort measures only, and she was referred to hospice. Now I will discuss the use of different IDH2 inhibitors among unfit patient AML in the frontline and in the relapse refractory setting. And the first study I'm gonna talk about is the enasidenib with azacitidine in L patient with the newly diagnosed AML. This is a phase 1b/2 trial that looked at the combination between enasidenib, azacitidine, as compared to azacitidine alone. They included 107 patients with IDH2 mutation. And as you can see, the overall response rate, which was defined as complete remission and complete remission with partial hematologic recovery, was achieved in 50% of the patient treated with enasidenib azacitidine, as compared to 12% in the patient treated with azacitidine alone. And you can see that complete remission was achieved in 37% in the combination arm. And this study was published in the Lancet Oncology by DiNardo and the group. However, when you look at the event-free survival for the same cohort and the overall survival, we can see that there was no significant difference in terms of event-free survival over free survival between the both arms, although the event-free survival was longer in the combination between enasidenib and azacitidine. This was followed by another study in the same cohort that looked at the health-related quality control, since the quality life measures are really important among elderly patients. And we can see that patients who were treated with combination group, they had a reduction in the quality of life measured based on the QLQC30 scores in all the dynamic domains, initially in the treatment therapy. However, this went back to baseline with the treatment. And there was no significant difference between AZA alone or ENA with AZA in terms of the quality of life measures. Another study I would like to talk about, which is a phase 2 trial that looked at a newly diagnosed AML patient with IDH2 mutation and patients who are having relapse refractory AML. In this study, they looked at 26 patients. They have 19 patients with relapse refractory AML and 7 patients with a newly diagnosed AML. And they look at the combination between enasidenib with azacitidine venetoclax, and they allow the use of the FLT3 inhibitor and venetoclax, as you can see in the diagram here. And they looked at the overall response rate and the complete remission rate. They have a composite outcome. And as you can see, all the patients with a newly diagnosed AML who were treated with enasidenib azacitidine combination, they achieved complete remission during the time of the study, as compared to 58% in the relapsed refractory setting. However, this study only included 26 patients and have a small sample size, and they allowed the use of FLT3 inhibitors and venetoclax in not all the patients, but in some of them. Now, another important use of enasidenib in the acute myeloid leukemia is in the relapsed refractory setting. And this is actually the first in a human study that was published by Stein and the group in Blood 2017 that led to the approval of enasidenib 100 milligram use in patients with relapsed refractory AML. In this phase 1/2 trial, they included 239 patients with AML, and they treated the patient with enasidenib and determined the dose of 100 milligram based on the pharmacokinetics and pharmacodynamic profile, and that demonstrated efficacy with overall response rate reaching 42% in the cohort. And you can see the complete remission rate was achieved in about 20% of the cohort. The grade 3 to 4 enasidenib related adverse event were indirect hyperbilirubinemia in 12% of the patient, and IDH inhibitor associated differentiation syndrome in 7% of the patients. This actually has led to the phase 3 trial that was published recently in a Blood by Deboton and the group that looked at enasidenib versus conventional care in older patient with late stage mutant IDH2 in relapsed refractory AML patient. This was a randomized open label phase 3 trial. They had randomization 1-to-1 to enasidenib 100 milligram, or the best conventional care, which include azacitidine, low dose cytarabine, or intermediate dose cytarabine, or best supportive care. And the primary endpoint was overall survival. And they look at key secondary endpoint, including event-free survival, time to treatment failure, and 1-year survival rate. There was no significant difference in median overall survival between the enasidenib arm and the best conventional care arm, 6.5 months versus 6.2 months respectively. However, patients treated with enasidenib had a better event-free survival and time to treatment failure. It was much more longer in this arm. And as you can see here, there was not significant difference in terms of overall survival, but there was significant difference in terms of event-free survival. Another important and landmark a trial done in patients with IDH1 inhibitor is the frontline use of the IDH1 inhibitor in combination with azacitidine in patients who are unfit for induction chemotherapy. In this a trial that was published in NAGM, they included patients who are more than equal 75 years old or having performance status equal to 2 or less, and severe cardiac disorder, severe pulmonary disorder. And the patients were randomized in 1-to-1 to receive either ivosidenib, IDH1 inhibitor, 500 milligram once daily, plus azacitidine, or match placebo azacitidine alone. The primary endpoint was an event-free survival defined as time from randomization until treatment failure, or relapse from remission, or death from any cause, whichever occur first. And as you can see, from the first Kaplan-Meier, there is a significant difference in terms of event-free survival between the both arms, favoring the patient who were treated with ivosidenib. And of course, there was significant overall survival favoring the patient in the ivosidenib arm. And as you can see, there was patients who are having age more than 7 or equal to 75 years in the subgroup analysis, they have better response in ivosidenib azacitidine. And the last trial I would like to discuss is the precision medicine based on the Beat AML master trial. Actually, this is a trial published in Nature Medicine, and it's actually an umbrella protocol that designed to assign patient with AML to specific treatment based on cytogenetics and molecular result returned within 7 days of sample recipient. They actually had 11 sub-studies included. So at the time of the sample recipient, patient will have molecular testing. And as you can see in the figure A here, they will substratify patient in multiple sub-studies based on the mutation present. And among them, we have IDH1, IDH2 mutation, TP53, and the FLT3 mutation. And patients who were treated in the sub-study, they included 224. And patients treated with a standard of care, they had about 171 patients. And as you can see here in the Kaplan-Meier, that the patient treated based on the Beat AML sub-study have a better overall survival as compared to the patient who are treated based on the standard of care therapy. And all these patients were unfit patients who were not candidate or eligible for intensive chemotherapy. So based on that, I would like to just put a scheme for summarizing the approach for patients with acute myeloid leukemia who are not fit for induction chemotherapy or intensive chemotherapy. The first question is going to be whether the patient going to be a candidate for HMA therapy. And contraindication may include a prior HMA therapy with resistance to that therapy or severe kidney disease or liver disease. If the patient is a candidate, the patient can be treated with HMA, but if not, we can consider low-dose cytarabine-based therapy or targeted therapy based on the VIALE-A trial as we discussed. However, if the patient does not have contraindication, we can look at the presence of IDH1 mutation. The presence of IDH1 mutation is going to make the patient a candidate to receive azacitidine or decitabine with ivosidenib. However, if the patient does not have that, we can look at the presence of venetoclax, and we can consider adding venetoclax with azacitidine based on a VIALE-A trial. And according to that, I think the next step that we need to look at in this like a specific group of patients is whether the use of the frontline IDH2 inhibitor with hypomethylating agent venetoclax can be used as even doublet or triplet in the frontline setting, whether fit patients with IDH2 mutation should receive 7+3 combined with IDH2 inhibitor with hypomethylating agent with or without venetoclax. And I think the magic question is going to be when and which doublet triplet to use and when to introduce these specific inhibitor during the treatment journey of these patients. And to that, I'm going to conclude my presentation, and I'm happy to discuss like any further trials and to answer any further questions.
So thank you very much for this very comprehensive clinical case on the presentations of the available clinical trials. This raised a lot of questions, and in fact, do not hesitate to send your question in the chat. We see now that for elderly patients with comorbidity, we have several possibilities to treat them. But still, it's not very easy on a daily basis when you have somebody that are more than 80. And I have a first question. When you use AZA plus venetoclax in the clinical trial you presented, this is 28 days of venetoclax. And I know more and more some colleagues reduce the use of venetoclax because we have a lot of neutropenia, a lot of toxicity. What are you doing currently? You are still using the 28 days of venetoclax, or are you using reduced doses or shorter durations of treatments?
Yeah, maybe I can take that question. So maybe a couple of comments actually. So outstanding presentation by Tariq, and I think a couple of points to highlight. So a lot of the therapies that were discussed basically were not available before 2017. This is when the first IDH2 inhibitor was approved, and it just has been amazing, the transformation of how we treat patients with AML. Because this patient, if 5-10 years ago, if she comes, she probably would be referred to hospice. This patient actually is, so she was 86, poor performance status, multiple comorbidities, secondary cancers, and she was somewhat tired actually. So when I met her the first time, it took me almost 1.5 months to convince her just to consider some kind of treatment. She wanted to go to hospice. So clearly, the first point is that you can wait for mutations in many patients. You don't have to treat AML immediately. Of course, if you have hyperleukocytosis or if you have like clinical reason, you can, but in many patients, especially in older patients, you can take your time, wait for your IDH, your play3, your other studies to come back. And some places this can take 2 to 3 weeks. So this is what we did here. We waited for the mutations. So when the IDH1 or the IDH2 came back, this presented an option. So we did discuss azaven, which was usually what I would do in patients with AML, even after the AGILE trial. We can talk about this in a bit, but I still would recommend venetoclax. You are right that venetoclax, while it's not like intensive chemo in the sense that you have to hospitalize the patient for 5-6 weeks, however, it can lead to severe myelosuppression that is similar to what you get with intensive chemo. So I tend not to call it low intensity. I tend to call it semi or moderate intensity type of treatment, because those patients will need transfusions 2 to 3 times a week. They will need prophylactic antibiotics, high risk of febrile neutropenia, and they have to come 7 days in a row to get the azacitidine, at the beginning of the cycle. There's high risk of hospitalization. So when we discussed this with the patient, she absolutely said no. So this wasn't something that she was going to consider. And to your question about the duration of venetoclax, we are realizing more and more that not only that you don't need the full 4 weeks in most patients, especially with subsequent cycles, but you actually could harm some patients, I think, if you continue with venetoclax non-stop dosing. If you don't do a bone marrow biopsy, this is something we often see in the community where the patients just keep going on venetoclax and no bone marrow biopsy is done because they could be in remission and you are just myelosuppressing them for no particular reason. So what I typically do in the first cycle is I do a bone marrow biopsy on day 21. If the blast count is less than 5% or if the patient is aplastic or hypoplastic, I usually would hold venetoclax and wait for count recovery. If they continue to be prolonged neutropenias, I tend to reduce. And I have some patients who get 2 weeks of venetoclax or 1 week of venetoclax, or they get the cycle every 6 weeks, 8 weeks. So you have to monitor these patients carefully, especially if they are in remission, because people can die in remission from febrile neutropenia and infection. So it's getting to remission is the first step, but then managing the myelosuppression is something that you have to consider with subsequent cycles. So once azaven was out, because this patient was not ready to go through all of this, and she certainly did not want to come 7 days in a row, the option of IDH inhibitor monotherapy came up. And I have to say, this is not an FDA-approved indication in the US, and I suspect anywhere. Currently, the label for inacidnib is in the refractory relapse setting. However, luckily in the US, sometimes we are able to get these medications off-label. Of course, you have to discuss with the patient that it's an off-label use and all the complications. But based on the studies that Tariq showed, we know that the activity appears to be similar or better. So you can expect a CR rate of around 20%. You can expect an overall response rate of around 4 months, and a survival. I would say around a year. You could, like, without treatment for someone like that, you would expect survival of only 2 to 3 months generally with just supportive care. So certainly it made sense as an option because it would not require coming often to the clinic. You could do it outpatient. It's a pill. So the patient was open to that. And we started it. And as I mentioned, or as you heard from Tariq, very important, this is not a pill like a CML TKI where you give the patient and then say come back in a month. Those patients can develop differentiation syndrome. They can develop LFT abnormalities. They are still suppressed and they need transfusions and all of that. And they can be slow to act. Those drugs can take 5 to 6 months even before you see a response. So in that patient, we did see signs of early differentiation syndrome. We managed her with steroids and she recovered very quickly. And she achieved a remission. And she continued almost 2 years on therapy. She developed a significant neuropathy that was not fully clear what's the reason, but by exclusion, we attributed to the IDH inhibitor because there was no other specific reason. So we did reduce the drug from 100 milligram to 50 milligram at one point, and that helped her symptoms a little bit. However, as you heard, she had history of multiple cancers, breast cancer, and she presented around 2 years after being in CR for AML. So she has been in complete remission for almost 2 years. And she comes with this new mass in her, huge mass over her scapula. And when imaging was done, I think she had more extensive disease, but the discussion that she needed radiation by itself was not sufficient, and she would need systemic therapy for that. And she was not open to this, which again, very understandably, she was, I think she was 90 or at that point, and significant pain and symptoms. So she elected to go to hospice. And for us, you know, again, in AML, I always tell patients that sometimes or many times you cannot cure the disease, but the goal is to control it into chronic condition, allow the patient to have normal blood counts, minimize the complications, allow them to have a good quality of life. And in this patient, this is what we achieved. She basically did not die of AML. She died of metastatic breast cancer, which again is a good problem to have, because, you know, we never used to have these problems. Like, you know, many of our patients would have other cancers. When you have AML, you forget about everything else, because most of the time the patient main problem and what leads to their demise is usually AML. So I'm seeing this actually in multiple patients now where they have other cancers or other things, and you're trying to figure out how to treat that in top of the AML therapy. So certainly this was an option that made a huge difference for the patient. I would say the addition of AZA to IDH inhibitors, clearly we have the agile data for the IDH2 with enasidenib. It's not clear that adding azacitidine to IDH2 is improving overall survival. So the clinical trial was, it's a randomized phase 2. The EFS was better, but the overall survival was not. And potentially, this could be also related to salvage use of IDH2 inhibitor enasidenib at the time of not responding to azacitidine. But the drug is approved in the refractory relapse setting. And this is one of the issues that people took with the AGILE study, that most of those patients did not get ivosidenib after AZA failure. And yeah, so this is why we decided to go with the enasidenib monotherapy per her choice. And the last point I'd like to make is, you know, I think Tariq outlined several kind of new directions in the treatment of AML. And I think the triplet combination is very important to consider. Those are probably the next frontier in AML, especially for IDH and FLT3 mutated AMLs. But also another potential is using 3 pills, right? Because we have oral HMAs, venetoclax and IDH inhibitors are already pills. So this is kind of mind-boggling, like to think that you can treat AML now with 3 pills. And of course, there are tons of, you know, issues that you have to handle about the toxicities and the dosing and financial issues, because each one of those is in the US is quite expensive. But again, I think it's a good problem to have, because in the past we did not used to have anything to give these to these patients.
So yeah, thank you for all these comments on that. Clearly highlight the key issue. And one of the things you highlight is that this is really important to have the mutations also in the elderly patient, because 10 years ago you say there's nothing to do in those patients. We don't need to screen for all the mutations. And in fact, now this is for this patient that this is very important, because we have this new targeted treatment. And we have to take some time before we decide the treatment in those patients to have all the results. And this is very new. The other thing is that the accessibility to the treatment, because of course, anti-DH2 mutation is not accessible everywhere, and this is not accessible as first line, even in France, where this is very easy to have access to a lot of treatment. We can't use it in front line because the lab say no to that. So we hope that we'll be able to use it in the front line very soon, because in those patients, this is, as you show, very effective. And this brings me to the question of the treatment durations. With this kind of treatment, it seems that this is a treatment, again, we are going to use the treatments until we need to stop for toxicity or of relapse. So far, we don't have, because in this patient, you have a minimal residual disease negativity at 2 months, I think. This is what you showed, Tariq. So do you think in the future we'll be able maybe to stop after 6 months of treatment in case of minimal residual disease toxicity, negativity? Because otherwise we can have also this toxicity, this neuropathy. So what do you think about that?
Yeah, this is again an outstanding question, and I do think it's something that we struggle with, and I think you have to make individualized decision based on the particular situation. So in this particular patient, we did discuss coming off the inacidnib altogether because her neuropathy was quite significant. She was not responding to inacidnib, but giving her all over condition, I estimated a significant risk of relapse if she stops, and if she was to relapse, it's almost certainly was going to be a hospice decision. So the question was, are you able to live with the neuropathy that you have with the reduced dose of inacidnib and having a good quality of life? If you are able to, then we would continue the inacidnib. If you are not able to, then we stop the inacidnib and kind of see what happens. So she was able to manage, not fully resolve the symptoms, slightly uncomfortable, but still, reasonable quality of life. But aside from the side effects, let's say in a patient who has no side effects, I think this is where it becomes more significant discussion. If you have no side effects, I tend to hesitate with the IDH inhibitors for sure. Most of the data with the IDH inhibitors clearly in the refractory relapse setting, and most patients are still relapsing. So you are not curing anybody. Many of those patients are not able to go to transplant clearly. So if you are not doing it as a bridge to transplant, long term, I don't think we could stop. Now, this is becoming more relevant, I think, with AZEVIN. There are certainly some patients who are several years out on AZEVIN, and they are MRD negative, and it's being explored basically to stop at least one of the drugs, and we still don't know, do you stop the azacitidine, do you stop the venetoclax? What I tend to do in most patients, if the patient really insists, I usually discourage against stopping, but if the patient is kind of have their mind set up that they want to stop, I usually tend to stop the AZA because it's you are giving it like injections 7 days in a row. Ven is the pill, you can take it outpatient. But I don't think we yet know. There are arguments for both ends, like you could stop the Ven, you could stop the AZA, or you could potentially stop both. So I think this is the next wave of trials. Certainly there are some patients who can who can have long-lasting responses on those therapies. So what you have to think about is that should the patient relapse? If the patient relapse, and again, those are older, unfit patients, no transplant option, let's say they don't have an IDH1 mutation or anything. So if the patient relapse, most likely, again, is going to be hospice. So I think you have to weigh kind of how bothered they are about coming and getting the injections. I tend not to stop, but I certainly believe that there is a subset of patients that potentially are functionally cured with these therapies, and it's going to become a situation like CML-TKI discontinuation, where we have to figure out how we can identify these patients and do clinical trials to identify them. But until that happens, I would say the standard of care is not to continue. But of course, you have to discuss on a patient-by-patient basis.
And did you try just to give the AZA every 6 or every 8 weeks in those patients?
I did. I do any, like in my mind, something is better than nothing. So this is how I present it to patients. So if we do 8 weeks, the one thing I did not try to do, but I think hopefully at one point, is replacement of oral HMAs. So those studies are being done. Oral HMAs, especially the oral version of decitabine, the decitabine-sidazoridine, is certainly being combined with venetoclax, with IDH1, with IDH2 inhibitors, with FLT. So all of these studies are being done. And many patients are actually asking us about those options. Hopefully at the next at one of the journal clubs in the future, we can discuss, but we have some patients on clinical trials, again, double oral therapy in remission, doing very well. So I think this is something that also might make it easier for the patient, that they don't kind of want to stop as much because they are pills, they don't have to come. But of course, again, I think the financial toxicity and the financial considerations, even if they don't affect the patient at the level of the system, have to be somewhat also considered at one point.
Because this is some long-term treatment in this case,
Exactly.
and we don't have a fixed duration. This is always the same questions.
Yeah.
I have a question from Dr. Suarez. I can ask you, Tariq, and after Amer, you can complete. This is a TP53 mutated acute myeloid leukemia, unfit patients. You can't put in a clinical trial. What is the best options?
Yeah, actually, this is a tough question. Yeah, but I think since like TP53, like it's very well known that to have like very worse like overall survival prognosis. I think like maybe hypomethylating agent with venetoclax. I'm not sure like if decitabine like shown better like outcomes in TP53 mutated patient compared to azacitidine. I don't know. What do you think, Dr. Zeidan?
No, I agree with you. I think this is probably kind of the most unmet need in AML at this point, is those patients who have TP53. And I would specify here multi-hit complex karyotype. Those are most of the AML patients tend to have complex karyotype and high allelic frequency type of mutations or multi-hit mutations. So those patients tend to do very poorly. The median survival is generally less than 6 months. So the only way to try to cure these patients is to get them to transplant. So I think your first decision is going to be always, is this a patient potentially candidate for transplant or not? And I have to say that even with transplant, the cure rate is probably, it's not zero, but it's less than 10 to 20%. So I still give the patient the benefit of the doubt if they are otherwise able to go to transplant, to try to get them into some kind of remission. Ideally, if you can make them MRD negative, even better. But if they go into remission, try to go to transplant. And then again, this is investigational, consider some kind of post-transplant maintenance, what we call total type of therapy. Now, in older patients or patients who have secondary AML, and this is, by the way, I think Tariq mentioned this, but 2 points I want to mention to this is, we historically used to define therapy-related AML as anybody who had received chemo or radiation and they develop AML, and many of them had complex karyotype TP53. And many people will automatically say, oh, therapy-related AML, older person, don't treat. This is very bad prognosis. This patient is, again, a good example, is that some of those AMLs either happened de novo, like, incidentally post previous radiation or chemo. So you really have to approach these patients the same way, like, what kind of mutations they have, not just say therapy-related, very bad prognosis. And the second thing is about the prognosis. So having NPM1 positivity is probably, even in older patients, we know it's a good thing with A7. I suspect with this patient also, it's probably part of why she had such a nice duration of response up to 2 years. Of course, it's tough to know because we don't have many such patients, but those even non-targetable TP53, NPM1 can help you approach those patients. In an older patient with TP53, I think the standard of care continues to be HMA with Ven if they are not, going to transplant. Of course, there's a lot of controversy whether venetoclax is adding anything to the HMA at this point. But for practical reasons, I think most of us, I certainly would not give HMA alone because for 2 reasons. One of them is that while it does not prolong overall survival, it does seem to increase the response rate. So those patients can get better counts, they become transfusion dependent. So I think it makes sense. And in younger patients, because the CR rate is higher, you can potentially get them to transplant faster. More patients will achieve remission. The downside is that venetoclax will give you some, myelosuppression. And so you have to individualize the treatment. But the biggest message is that I think you should not think of these patients as kind of, no way to cure them. And some people even don't. I have heard in some centers they even refuse to transplant an otherwise fit patient who has TP53 complex karyotype, which I think is really not the right thing to do, because while it's a small number, some of those patients can be cured.
I completely agree with you, because there is some curves that show, yeah, this is the same outcome without allo. But in fact, now we have also these new interventions with the post-transplant maintenance. So now what we are trying to evaluate, this is the use of oral azacitidine and venetoclax, low dose of them, to start them very early after transplant as the maintenance, and we think that we have some good results. So probably maybe we'll improve the outcome of those patients. So definitely we have to discuss them for the transplant when they are fit. So I am completely in line with you regarding the approach on the treatment. So I think we're going to an end. I don't know if you have a last comment, Professor Zeidan, Dr. Kewan.
On my end, again, thank you so much. This is a very nice forum, and to interact with people, and people can can email us or tweet us. Both me and Tariq are on Twitter. They can reach out to us for any questions, and hopefully we can have future collaboration in the future. Thank you.
Yeah, thank you very much for having us, and hopefully we can have further episodes with each other. Thank you very much.
So thank you again to both of you, and we'll have another journal club very soon. Thank you. Bye.